So I think with that, Betsy, you are up.
Sure.
So tell them your fun fact.
My fun fact?
Yes, tell them who you are.
Hi. Well, first of all, I have to say, what an impressive group. And I've been talking with Andy about you guys for the last several months planning. And it's just a real honor to be here. So my name is Betsy Risendal. I'm a cancer epidemiologist. I am not a clinician. I help on the other end of the spectrum in terms of designing and planning research studies. You do want me to say my fun fact? I thought you were going to guess. Okay, I went to the Eastman Conservatory for Music for Organ Performance when I lived in Rochester, New York, and I play a wicked version of the girl from Ipanema.
I want to hear it.
Yes.
Yeah. No.
So I will tell you the more funner fact, which is not a word, but so Betsy actually went to high school with David Spade, the comedian, and he had a wicked crush on her, and I saw her yearbook that said to Betsy, of course, you know, at the time, you're a fox. I saw that.
Wow, I would have started with that fun fact.
Yeah. So today we're gonna, and I'm an associate professor here in the Colorado School of Public Health, and in community and behavioral health. So I'm going to share with you, and I have an issue with chords when I teach. My students are always like, she's going for the chord. Be careful. So if anybody sees me starting the trip, just holler. I will take your advice. Thank you so much. Okay, so we're going to talk about the end of the continuum of cancer prevention and control. So the first thing I wanted to let you know is that there is an overall organization that's specific to cancer survivorship. They were formed in the mid-90s, and it's the National Coalition for Cancer Survivors, or NCCS. And they were really the ones that first changed the word from cancer victim to cancer survivor, and started ensuring that the patient perspective was part of public policy. They're still a very active group on the survivorship, and again, this is all cancer survivors together, and they're involved in many Institute of Medicine reports and public policy. They were very vocal in terms of healthcare reform, making sure that that cancer survivors' perspective was included in that. And so that's another great supplemental resource for you. Again, not specific to colorectal cancer, but to survivorship. So in terms of my own work and what's happening in the field of survivorship care, these are kind of the biggies that have come about in the last year or two. So the first one is distress screening. So have any of you been screened for distress at any time in your diagnosis or treatment? No? Couple people. Okay. What did that look like, if you don't mind me asking that? You don't have to tell me your results, but I mean, was it a nurse, a doctor, was it part of a clinical encounter?
I think through the social worker, probably.
Okay, all right. So, so there's a new standard from the Commission on Cancer that is relevant to accreditation. It's supposed to take effect at the end of this year. That says that cancer patients from the point of diagnosis at least one point in time should be screened for distress. It's not specific in the way that in terms of when this screening should be done or who should be doing the screening, but it just said that there should be a screening and a referral process at least one time. So as you can imagine, there's a lot of research and study going on in terms of how to do this. So there are a number of validated tools, and there's also a lot of research going on in terms of how this is implemented. So it could be a paper and pencil version administered by the scheduler, all the way up to something that's integrated to your electronic medical health record and that is automatically perhaps delivered to you in your health portal, where you could fill it out periodically and then have the results available for your next clinician visit. But what's happening right now in the real world is that only, estimates vary, but it's about 45 to 75% of patients overall in the U.S. are being screened, is our best estimate. And then of those patients who are found to be distressed, and by the way, that was a very intentional use of that word, due to perhaps some potential stigma associated with mental health. So distress really encompasses any kind of a struggle, anxiety, depression, spiritual, cognitive, what have you. But what's So only 45 to 75% of the patients are being screened, and of those who do have severe distress, only about 50 to 65% are being actively engaged in some sort of referral process to deal with that distress. So this is, I think, a real hot topic where advocacy could be an important issue in terms of helping to further this process along, helping to advocate for good distress screening practices and promoting implementation. The other hot topic is treatment summaries and care plans. Has anybody received a written summary of their treatment? Okay, we have a couple. This group is good group, good services over there on the back. Perhaps are you
MCI Hospital up in Front Hedge.
Okay, okay, very good. So just like the, just as if you had a surgery or were in the emergency room, you typically get a discharge statement, right, that says, okay, this is what happened to me, this is what I received, and now this is what I'm supposed to look for after the fact, and when I'm supposed to contact my physician if I experience certain effects, right? Well, there's no, excuse me, I'm struggling with my words this morning. There's no similar document that takes place after cancer treatment. So there's really no bookend, if you will, on an episode of care. And so the Institute of Medicine convened an expert panel, and this was one of their recommendations, that there should at least be a summary of the treatment and then a very basic written care plan that says this is what should happen, this is what you should be looking for, this is how often you should be having your colonoscopy or other tests following cancer diagnosis and treatment. So this standard has also been adopted by the COC, the Commission on Cancer, but the implementation date keeps getting delayed because this has been, it's very onerous for doctors and healthcare systems to figure out how to prepare these documents. And what's the big issue is how to maintain them, right? So as these new discoveries about genetics and surveillance issues come in, how do we keep these written documents updated to make sure that survivors 5, 10, even 20 years out, are kept in the loop with these new discoveries? So again, making sure that you get this written plan, and what the research is showing is that the written document itself, not surprisingly, isn't all that helpful. What's really helpful is the encounter where the information is explained to you. So making sure that colorectal cancer survivors are receiving these documents and that they're engaging in conversation with their doctors about these written plans is key. And then the other big development is, the other thing I wanted to mention is that we've been here in Colorado part of the Livestrong Center of Excellence program for several years with the Hutch. And we did a study looking at, across our 7 centers, looking at these written plans, what was the % agreement or the concordance with the Institute of Medicine standards in terms of the information contained in these reports. And we found that even of these 7 centers, which presumably would be the best of the best in terms of survivorship, that our scorecards weren't 100%. We were not able to complete all of the fields that were recommended by the Institute of Medicine. And the lesson here, and Patty Gantz, who's probably one of the world's foremost experts in cancer survivorship research, she wrote an article about this, basically saying, let's not let the perfect be the enemy of the good. It's the conversation that really matters in the clinical encounter, and if there's pieces of information missing in that written plan, they can come up in other ways, but let's at least start this process and getting patients the information that they need. And then the other big development has been in the last year and a half or so, the development of the NCCN, or National Comprehensive Cancer Network, survivorship guidelines. So just as there are guidelines for how to diagnose and treat colon cancer based on different presentations, there's now algorithms for how to assess different issues post-diagnosis, and decision trees in terms of what professionals should be involved, and recommendations for evidence-based strategies. So just to give you an idea, these are some of the things that the NCCN has specific guidance on, again with treatment algorithms and referral recommendations for evidence-based programs. So everything from anxiety and depression through to preventive health. And the one probably hottest news in terms of research, in terms of survivorship for colorectal cancer, is the benefits of physical activity. And other than breast cancer, there's the most compelling evidence that physical activity makes a difference in colorectal cancer survivorship in comparison to all the other cancers. So generally, does anybody know what the recommendation for physical activity is?
30 minutes a day.
Right, 5 days a week, right. And the other key is that it should be at least moderate intensity exercise, so that's about a 10-12 minute mile or so. So you can't just be strolling along and getting in your 30 minutes. You really do have to be active. And so there's been long-standing evidence that physical activity has benefits on the prevention side of the continuum. And recent meta-analyses, which is where they take the results of lots of different studies and combine them as if they were one study, are showing that there's similar high benefits for physical activity. And the estimate is 38% reduction in CRC mortality amongst people who engage in the recommended levels of physical activity versus those who do not. So the issue with this studying physical activity is something that plagues all of survivorship research, and that most of our data is from observational studies. Because if you think about the kinds of things that we are trying to study, it's not a supplement where there's a defined dose, and it's easy to know who's taking it and who's not taking it. You can imagine that many of the strategies for addressing things like fatigue, which might be anything from medication to, again, engaging in some sort of low-level physical activity to build up strength. Those doses of those kind of interventions are really hard to measure, and so they're really hard to study the effect. But that doesn't mean that this can't be good science in the field of survivorship. The fact that that doing randomized trials is more difficult means that we have to be really good about designing our observational studies and our cross-sectional studies. Cross-sectional being we look at two things at the same time, observational being that we follow people in time. We're just not assigning them to groups like in a randomized trial. Yeah.
I was thinking a good example of that would be with technology, how it's helping us.
Yeah.
How many people, or maybe how many of us in the room, I don't have one on, but have a Fit Watch on
Sure.
that tracks. Why can't something like that be designed that if you're having a fatigue day, you're hitting fatigue day and that
Right.
information is downloaded and shared, in that aspect, or your pain level is
Yes.
higher than usual. I mean, technology is
Yes.
probably going to be our best friend in this aspect.
Yes, you're absolutely right, and there's studies going on with the use of mobile technology, and really what's going to be key is how to get that, because this big data thing can be overwhelming, right? And so getting all these data points in and churned up and digested in a format that then is actually usable so that you and your provider can sit down and look at patterns over time and that kind of thing. But you're absolutely right. That is a big advance that we're very hopeful about.
One quick partnership I wanted to mention is, and Angie just reminded me, Medosity. So I don't know if anyone's seen it as a Fight CRC website, but it's specifically for all of the things that Betsy mentioned, and we even at the university looked at the possibility where there is the tracker of all the survivorship pieces, so physical activity, symptom tracker, management. Yes, ma'am, that's the one.
My picture's on here, I didn't know that.
What's that?
My picture's on here, I didn't know that.
So this Medosity 360.
We signed a waiver.
Is one of the apps that we have available, to your point, Winora, that really helps with those tracking pieces, so that's great. Elaine, I know you had a quick question and you were going to go.
What is anthracycline?
Oh, it's a chemotherapy drug.
Okay. It's one I hadn't heard of.
Yeah, it's more prevalent in breast cancer. Is that right, Doctor? So anybody can get on and look at these NCCN guidelines. You just need to file an account and an email. I've done it, and I don't get a whole bunch of junk mail from them, but doing so allows them to track who's looking at their guidelines, and you can get in there and for yourself look at these different treatment algorithms. Yes?
These guidelines are good. I'm a part of the website, so I'm familiar with them.
Okay.
But my question is this. There needs to be, maybe it's just with my oncologist, like after treatment I'm having these issues and I'm going to her and I'm speaking to her about this, and she's just telling me to go to my primary care physician. And I'm like, but you're an oncologist. Like, why is there, do they speak with oncologists, or are oncologists required to register with the NCCN to know what a typical patient will go through? Because she's talking to me like I'm just crazy. And everybody that I'm speaking to in my support groups are like, well, no, everything you're experiencing is normal. But I'm not feeling that way when I'm speaking to my oncologist. So are they required to know these guidelines, or how does that work?
Maybe get us a second opinion.
Well, I've switched since then, but I'm not the only one that feels this way.
Yeah. Do you want to, as a provider, would you?
Well, I think, one of the issues that we have from our end, but I mean, that's probably one of my problems, is I get into things that I really don't have any professional training in, like someone will be telling me a lot of things that are related to their life and stressors and, what should they do to promote the best health. But it is a good point. We don't really get that training. And so that's why you see so much of this turfing back to primary docs. And I agree. I think I think the best thing actually would be for all the universities and cancer care places to really have survivorship clinics. And we have one, but it's very difficult to get, they're never big enough. And the reality is, you don't want to it's not just special cases, it's everybody.
Correct.
And actually, I think survivorship is really changing, because being in drug development and now seeing that a lot of our drugs, people are on them, like my patient that you'll meet later, for 2.5 years. Now, the issue is no one's dealing with him as a survivor, because he's in active treatment. And it's become a chronic disease for a lot of patients, and that is almost completely ignored. And I tried to bring this up with the Livestrong CEO, and it's just sort of like, they really want to put everything in one camp or the other, and it's like, no, I think in the future, we're going to have a lot of people that are in active treatment, but surviving for years.
So guys, we have to, I'm sorry, Betsy's going to be available a little later today. So we're going to have her finish up her presentation, because we have another presentation, but we will have time for further discussion. So Betsy, if you want to go ahead, sorry to,
Sure.
but we'll definitely continue the conversation shortly.
Sure. So this is just some gaps in survivorship research, particularly relevant to colorectal cancer, is understanding mechanisms of where are the benefits from physical activity coming from, what is the mechanism, can we capitalize that in some other interventions. And then there's a really good article in your packet that I would encourage you to look at, top 10 things that for colorectal cancer patients might be thinking to ask their doctors. And it's a really nice summary of the evidence. And it's a very straightforward, easy read. So I would encourage you to look at that. We'll go ahead and just skip the audience response, because the answers to these questions are all in that article. And then the last thing I wanted to talk about is the end of the continuum, palliative care. And if you get nothing else out of today in regard to palliative care, it's this, which is that palliative care includes hospice, but is not the same thing as hospice, okay? So it does not mean that a patient is terminal. They can still be seeking disease-directed treatment. And it's really focused on pain and symptom management. And then I wanted to let you know that we have a nationally recognized network here headed up by Dr. Jean Kuttner, who prepared these slides. And Dr. Kuttner is head of a network that's really trying to move the research forward in terms of standardizing instruments, promoting well-done studies in palliative care, and importantly, disseminating the evidence about the benefits of palliative care. And so you can see here that this is, for example, a recent review of the evidence showing improvements across a variety of outcomes, patient satisfaction, quality of life, and in some cases, even survival. So there's been several reports, but these are some resources that Dr. Kuttner wanted to make sure that you had and knew about. There's an Institute of Medicine report on end-of-life wishes. And this is a great book by a surgeon who, based on his experience with patients and family, on the experience of living and dying and what matters in the end. And she highly recommends this book. And there's also a dedicated website getpalliativecare.org that has wonderful resources, including patient resources.
That's awesome.
So, and I will be back for the 3:30 this afternoon?
Yes.
Okay.
So, so thank you so much. And I know a couple of people